Okay, Assalamu alaikum rahmatullah wa barakatuh, everyone. I'm Abdulrahman Farahat. I'm a fourth year medical student, and today I'm delighted to be giving you the renal pharmacology crash course. Um, it's going to involve four to five lectures. Inshallah, this will be all you need for the exam, covering all the main points and a complete review, bismillah. If you have any questions, feel free to text me or email me if you use email. Moving on to, or let's actually begin with our first question. A 62-year-old man comes to the office due to decreased libido and failure to achieve satisfactory erections. The patient has coronary artery disease and heart failure with reduced ejection fraction and was prescribed spironolactone therapy several months ago. Other medications include aspirin, lisinopril, furosemide, and metoprolol. Blood pressure is 110/70 and pulse is 70 per minute. Oxygen saturation is 95% on room air. Examination shows a left ventricular S3 and trace pitting ankle edema. Breast examination demonstrates bilateral enlargement with mild tenderness. Which of the following is the most likely cause of this patient's current symptoms? I'm going to give you guys a couple of seconds to answer. Okay, so let's take the main red flags from this question. First, the patient presented with decreased libido and a failure to achieve satisfactory erections. This is important. Secondly, you could see over here, the patient is taking multiple drugs, and breast examination demonstrates bilateral enlargement with mild tenderness. So you're thinking more about gynecomastia. But so the main drug we're talking about is spironolactone. And what are the adverse effects of spironolactone? Gynecomastia, hyperkalemia, generally anti-adrenergic activity, and this is why the patient presents with decreased libido and failure to achieve satisfactory erections. But how does this happen? Again, so the mechanism of action of spironolactone is an aldosterone receptor antagonist, and so it has a very similar structure to other androgen receptors, and so it could also have a partial antagonizing effect on those receptors. And this is why you'd have decreased testosterone effects and anti-androgenergic activity. Secondly, because the testosterone is not binding and there is no effect, there would be increased testosterone, and this high testosterone would eventually be converted to estrogen. And this estrogen is why this patient starts developing gynecomastia. So first, you'd have the anti-androgenergic activity, decreased libido, and unsatisfactory erections. Then you'd have increased estrogen leading to the gynecomastia. So out of all the answers, the answer C makes the most sense, which is impaired binding of testosterone to its receptor, leading to all of this sequence of events. Okay, moving on to our next question. A 30-year-old woman is ascending on a high-altitude hiking trip and starts to experience acute mountain sickness. A medication with which of the following mechanisms of action can treat her symptoms? Again, this question is pretty much a recall question. You need to memorize it as it is. The carbonic anhydrase or acetazolamide work, or carbonic anhydrase inhibitors, work in the proximal tubule, and their indication would be something like an acute mountain sickness. This is the main indication, not the main, but one of the main indications you would give acetazolamide for. Another indication would be glaucomas. But remember, carbonic anhydrase inhibitors are used for acute mountain sickness. So our answer over here would be A. This drug inhibits carbonic anhydrase in the proximal tubule, leading to bicarbonate diuresis. All right? Simple, straightforward, and recall question. Moving on. We have a 62-year-old man. He comes to the emergency department with severe shortness of breath and orthopnea. His medical history is significant for long-standing hypertension and myocardial infarction a year ago. Physical examination reveals elevated JVP, crackles in lung auscultation, and pitting edema of the lower extremities. Chest X-ray shows pulmonary edema. The patient is given a medication and experiences brisk diuresis with significant symptom relief. The drug most likely used to treat this patient's condition predominantly acts on which of the following nephron segments? So again, you need to know which drug would be given in this case and where it acts. All right, assuming you guys got the answer, straightforward. This is loop diuretics. Why is it important? Because the patient has severe edema in the body, severe fluid overload. He has elevated GVP, his heart is failing, there's pitting edema, there's pulmonary edema. You need to get rid of all the fluids in the body. And so the best diuretic for that would be loop diuretics, such as furosemide. And from its name, loop diuretic, where does it work? It works at the loop of Henle. To be specific, the thick ascending limb. All right, so our answer is C, loop of Henle. Perfect. Moving on, a 70-year-old man with hypertension is prescribed a medication. At his next visit, he reports significant improvement in his blood pressure. But routine labs reveal new onset hyperglycemia and hypercalcemia. Which of the following medications is most likely responsible for these findings? Again, straightforward adverse effects, hyperglycemia, hypercalcemia. If you guys remember from our previous file, hypergluc, our answer would be C, hydrochlorothiazide, which is a thiazide diuretic. Okay, so really quickly about the diuretics lecture. You guys already took this in CVP once, and it's straightforward, simple, and inshallah, quick revision. We discussed thiazide in details, your drug names, and where does it... Okay, so now I want to focus on something with you. In CVP, you guys took these drugs, and you took their indications, such as for hypertension, for heart failure, how to use this, how to use that. Now, it's very important to remember where the drugs act in the kidneys. And this is why I expect them to ask you more about that, where the drug acts rather than their mechanism of action or stuff like that. So over here, need to remember, thiazide works in the distal convoluted tubule. Of course, it inhibits the sodium chloride pump or channel. And then you also have their adverse effects, like the question you said, hypokalemia and hyponatremia, along with hyperglycemia, lipidemia, uricemia, and calcemia. For loop diuretics, exactly same thing, ODANG, but it acts in the thick ascending limb. Finally, the potassium sparing diuretics, which you guys did not take in the cardiac in CVP. However, again, you have spironolactone and eplerenone, which act by inhibiting the aldosterone receptors, where exactly in the cortical collecting tubule. Similarly, you have amyloid and trimethylene, which act in the cortical collecting tubule on the epithelial sodium channel. It directly inhibits sodium absorption. And so if you inhibit sodium absorption, more fluid will be excreted, more urine output. Okay, adverse effects, again, very important to remember, gynecomastia and anti-androgenergic activity. Finally, because they are called potassium sparing, so you're sparing the release or excretion of potassium, you have high potassium in the blood, and this is characterized by hyperkalemia. Okay, now the new diuretics that you guys did not speak about at all before are acetazolamide, which is a carbonic anhydrase inhibitor. And what does carbonic anhydrase do? It essentially helps the conversion of bicarbonate and a proton into water and carbon dioxide. And so essentially this allows you to absorb more water into the body. And so if you inhibit that, you're releasing more water in your urine. And this is the action of acetazolamide. Where does it work? Proximal convoluted tubule. I forgot to write it down, but remember it works in the proximal convoluted tubule. Now, it's not that effective actually in the proximal convoluted tubule. However, it could still be used for other indications, such as the ones we mentioned, mountain sickness, and if you have glaucomas. Adverse effects, very low yield in my opinion. However, if you need to remember something, maybe calcium phosphate stone formation, metabolic acidosis as well, because you won't absorb any bicarbonate. The bicarbonate gets released into the urine. Okay. Now back to mannitol. It's an osmotic diuretic. Essentially, it means the molecules enters the blood and it starts absorbing fluids to it. So this is what we call as fluid shift. So fluids start shifting from inside the cells and inside the tissues to the extracellular fluid or the blood in general. And it goes from the blood, goes into the kidneys, and it gets excreted because you have a lot of fluid and it gets excreted in the kidneys. So this is the action of mannitol. Again, where does it mainly act? The proximal convoluted tubule. Their main adverse effects is you should not use them in any high volume or volume overload situations such as cardiac failure, pulmonary edema. Those situations where you have generally the heart is not able to pump, or if you have too much pulmonary edema that could cause shortness of breath and so on and so forth, you should not give mannitol because it could exacerbate that or increase it because, as we mentioned, it takes fluid from inside the tissues to the extracellular fluid volume, which you don't want in cardiac failure or pulmonary edema. Now, it could also cause hypo or hypernatremia. So at the beginning, the extracellular fluid would be increased. So you'd have hyponatremia, you'd have more water than sodium. And then after that goes to the kidneys and you start excreting the water, the hypernatremia starts happening. Now, finally, you have conveptan, which is an ADH receptor inhibitor. And this essentially means, and ADH, usually, what does ADH do? It binds to its receptor and absorbs water. So now you're preventing that and you're releasing more water. This is what conveptan does. Adverse effects, not that significant, and you probably will not get asked about. Now onto, again, this is a picture of where each works. So remember, mannitol, acetazolamide work in the proximal convoluted tubule. Loop diuretics act in the ascending loop of Henle. The thiazide diuretics work at the distal convoluted tubule, and spironolactone and the rest of the potassium-sparing diuretics work at the collecting duct. So moles, okay? Now, one last thing I need you guys to remember are indications. So for indications, again, I expect them to ask you about a couple. Remember, simplify it on yourself. If there is any sort of fluid overload or edema or a lot of blood in a lot of volume in your blood, you give them loop diuretics. It's really simple. It releases that volume. It decreases, it causes an extracellular fluid shrinkage. This is loop diuretics for edema, fluid overload. If you have any raised intracranial pressure or intraocular pressure, these are primary indications. Number one indication for osmotic diuretics, such as mannitol. Finally, for hypertension, thiazide diuretics, for diabetes insipidus as well, thiazide diuretics. Now, something I need you guys to remember is for osmotic diuretics, when is it contraindicated to give osmotic diuretics? We already mentioned it. Congestive heart failure, pulmonary edema. Pulmonary edema is very high yield for some reason. It gets asked about a lot. I've seen it in a lot of questions. But remember, osmotic diarrhea should not be given in situations of pulmonary edema. Now, I know this table looks a little all over the place. This is essentially everything we said. Congestive heart failure, you'd have a lot of fluid you need to release. Pulmonary edema, you'd have a lot of fluid that you need to release. Give loop diuretics. Hypertension, I said we give thiazides. Kidney disease and nephrolithiasis, I didn't mention much because I doubt you get asked about. Hepatic cirrhosis, again, it could cause fluid overload. It could cause ascites. It cause a lot of edema. Again, you could give loop diuretics. Edema, loop diuretics. Diabetes insipidus, already mentioned thiazides. Intracranial pressure and intraocular pressure, number one is osmotic diuretics. Mountain sickness, we already said carbonic anhydrase. Now over here is a summary of basically everything before except nephrolithiasis and kidney. And so loop, osmotic, and thiazide diuretics. Do not give in pulmonary edema. Boom, that's done for this lecture, inshallah. No question out of what I just mentioned. Moving on, a 65-year-old man with chronic kidney disease is being treated with IV vancomycin for MRSA pneumonia. His serum creatinine has recently increased. What adjustment should be made to his dosing regimen? Very common sense. Patient is taking vancomycin and his serum creatinine starts increasing, indicating renal issues. And so the answer would be B. You'd extend the dosing interval to once every 24 hours. Of course, you would not shorten it. You would not give it more because the patient is already struggling in giving it. Giving it at the same dosing frequency does not make any sense either because, again, your kidney is failing. Changing to oral vancomycin or doubling the current dose would not make any difference. Doubling the current dose would actually make it worse. All right. Moving on, a 62-year-old man with hypertension and type 2 diabetes mellitus is hospitalized for worsening edema and fatigue. Laboratory tests reveal elevated serum creatinine and blood urea nitrogen levels, indicating declining renal function. He's currently taking multiple medications, including an ACE inhibitor, a beta blocker, a loop diuretic, and an aminoglycoside antibiotic for a recent infection. Which of the following classes of drugs should be carefully dose adjusted in this patient due to his renal impairment? Again, this question asks you about which drugs. I have a list at the end I'm going to discuss about which drugs actually you need to specifically take care of in those situations. And the answer to this question would be aminoglycosides. If I remember, aminoglycosides, along with other drugs, if a patient presents with some sort of renal impairment, you should adjust the doses. Okay, so the answer is D. طيب. Now on to the dosing adjustments in renal insufficiency lecture. So something to start the discussion, I'll go back to basic PUD, pharmacokinetics, and pharmacodynamics. Really quickly, pharmacokinetics is what the body does to the drug. So what the body does to the drug. And there is a mnemonic for it, ADME, A for absorption. So how the body absorbs it. Does it absorb it from like the veins? Is it given IV? Is it oral? How exactly? D is for distribution. M for metabolism, how is it metabolized in your liver, in your kidney, and E for excretion, how is it excreted, again, through feces or through urine, whatever it is. So this is for pharmacokinetics. And you could imagine if you have low metabolism of a drug, you'd have a prolonged drug effect. If there is a low clearance of a drug, you'd have the drug in higher dosages in your blood, and it could cause more toxic effect. But this is generally for pharmacokinetics. For pharmacodynamics, you need to understand what the drug does to the body. So if I give you an example of thiazide diuretic, what does it do? It inhibits your sodium chloride transported in your distal convoluted tubule. This is the pharmacodynamic of that drug. Right. Now, here's something else, which is estimating your renal function. This equation, I don't think it ever got asked about, but it always hit me as something high yield to know. It measures your creatinine clearance in those renally impaired patients. And in case the doctor decides this time she wants to ask you guys a question about it, just remember the equation and put in your variables that were provided. So just remember the equation as it is. If it's a female, do not forget to multiply by 0.85. And once you get that value, you could compare it to your CKD stages over here and essentially adjust the dose accordingly. Now, how would you adjust the dose? The value you get, you divide it by, I prefer 100 because it's a simpler number, and you get a percentage. This percentage you multiply it by whatever dose is given. Okay. Now, let's go finally to the principles. So essentially, two main things. Either you reduce the dose of the drug or you extend its interval. So whatever drug is given, if it's given along a 2-hour period, you could extend the interval, or you could reduce its dose. If it's 8 milligrams, you could give half of that, 4 milligrams. And again, you could combine between those accordingly as well. Right. Finally, the drugs to keep in mind are 3A's and 1C, so antibiotics such as vancomycin and aminoglycosides, antidiabetics such as metformin, analgesics such as NSAIDs and morphine, and finally cardiac such as digoxin. That is all you need. This lecture, very straightforward, inshallah. It makes common sense. Also, a patient with renal impairment, he's receiving a drug that's worsening the renal impairment. Khalas, either you extend the period, reduce the dose, or just substitute it with another different drug. Nothing will come out of this, inshallah. Very straightforward and nothing else. Right. Moving on, let's start with this lecture. A 62-year-old woman is admitted to the hospital for a living donor kidney transplant. She had a history of end-stage kidney disease due to diabetic nephropathy and has been undergoing hemodialysis for the last 2 years. The transplant surgery is performed without complication, and the patient demonstrates good urine output after. To help prevent rejection, she is given a medication that inhibits the conversion of inosine monophosphate to guanosine monophosphate, primarily in lymphocytes, causing reduced proliferation of activated lymphocytes. Which of the following medications is most likely being used in this patient? Again, very straight mechanism of action. The answer would be B, mycophenolate. So mycophenolate acts by directly inhibiting inosine monophosphate, which is important for your purine nucleotide synthesis. And so if you inhibit it, you don't have any purine nucleotides, and it specifically acts on lymphocytes. And I'm going to talk more about that later, inshallah. So the answer for this question is B. Now, a 45-year-old man who recently underwent kidney transplantation is started on an immunosuppressive regimen. 1 month later, he presents with elevated creatinine, hypertension, and confusion. Which of the following medications is he most likely taking? This is asking more about the adverse effects of the drugs. And the answer would be D, tacrolimus. So again, we're going to talk into details. Something to keep in mind here is the patient has elevated creatinine, indicating nephrotoxicity, hypertension, and confusion, which you could think more about, neurotoxicity. And so how to differentiate? The main drugs that could cause this are calcineurin inhibitors, and you have two options here, cyclosporin and tacrolimus. And which one is it? Tacrolimus, because of the neurotoxicity, the confusion that happened. It's more specific for tacrolimus. All right, the answer is D. Finally, we have a 45-year-old man who undergoes a kidney transplant and is started on immunosuppressive therapy to prevent organ rejection. Along with corticosteroids and calcineurin, he receives an intravenous monoclonal antibody that binds specifically to the alpha chain, CD25, of the interleukin-2 receptor on activated T lymphocytes, thereby preventing further T cell proliferation. Which of the following agents was most likely administered? And the answer to this would be B, basiliximab, which is an interleukin-2 antibody, not an interleukin-2, a CD25 antibody. It acts as an interleukin-2 receptor antagonist. All right. But so for the immunosuppression therapy lecture, this is basically a simplified diagram of, very simplified, of what happens in your body. There is more sequences to this, but I tried to simplify it as much as possible, as relevant to the drugs you guys are taking. So starting over here on the left, you have step one, where the T cell, and you have an antigen presenting cell. The antigen presenting cell picks up an antigen and it presents it to your T cell on the CD3. After that happens, there is co-stimulation through this receptor, CD80 or 86, binds to the CD28 on the T cell. And this causes the activation of the T cell. It causes a lot of pathways inside, specifically the activation of the calcium-calcineurin pathway. And at the end product of this pathway results in a lot of interleukin-2. What does interleukin-2 do? Interleukin-2 goes and binds to CD25 on other inactivated T cells, and it causes activation of an mTOR pathway. This leads to the T cells to become more activated. They start dividing and proliferating, and essentially it activates the whole immune response to start attacking this specific antigen. But if you guys have already studied the lecture, hopefully you guys did, and know the immunosuppressants will act on one of those steps to avoid or to calm down the immune system. Like, so the main concept here is you have two types. You have induction therapy and the maintenance therapy. Induction means in the patient is recently out of a kidney transplant surgery, and you need to induce the immunosuppression right now. You need to stop the immune system this second. So you give them one of three drugs, which is interleukin-2 receptor antagonist, as we already mentioned, basiliximab. And if you go back to the diagram we already showed, interleukin-2 comes and binds to the CD25 receptors and the T cells. And so if you have an antagonist to that, it inhibits this binding, and essentially the T cell will not divide and proliferate. Then you have an anti-CD20 antibodies. We did not discuss this on our original diagram, and it comes in B cells. So over here, you can see on your left, the B cells have multiple receptors, including a B cell receptor, a CD19, a CD20. Everything has its own activity. So I wrote them down over here. A B cell receptor gets stimulated by an antigen, and this causes a CD19 to bind to another antigen on the other antigen presenting cell and causes amplification of the signal. And finally, through CD20, you have calcium entry. Now, this is very basic immunology. You don't need to get into this detail. All you need to know is that rituximab comes, and what it do is it inhibits the CD20 and it closes it off. So you won't have calcium entry, and you won't have the activity or the action of B cell. Like over here on your right, you can see the direct effects of rituximab. So here it could cause apoptosis. This is provided from your lecture. Rituximab could cause indirectly complement-mediated lysis of the B cell, and it could cause antibody-dependent cytotoxic or cell-mediated cytotoxic killing. Okay, so these are the ways the rituximab drug could work, which is essentially antibody against CD20. Finally, you'd have anti-lymphocyte antibodies, and from its name, we have lymphocyte. Each lymphocyte, as you've seen, it has multiple CDs like CD3, CD28, CD20, CD19, whatever it is. And you'd have antibodies against those specific antigens on the lymphocyte. Right. Now, really quickly for their adverse effects. Now, what you need to remember is that all induction drugs are given as an infusion. So the number one adverse effect that should come to mind is infusion reactions. Right. Second thing is for rituximab, you need to remember Farahat, it's not that important, but it was mentioned in your lecture, if I keep it in mind if they decide to ask about it. And it could cause reactivation of your hepatitis B, a latent hepatitis B infection, or generally any other viral infection. And this is it for the induction drugs. Then you have your maintenance drugs. Again, one of three, you already know about one, which is corticosteroid. We're gonna speak about them later. Calcineurin inhibitors, if we go back to our diagram over here, where does calcineurin come in? It comes when the T cell gets activated, and through calcineurin pathway, it causes the release of interleukin-2. And so if you inhibit calcineurin, you won't have interleukin-2, you won't have the activation of other T cells. So this is for calcineurin pathway. For antimetabolites, you have mycophenolate, and we already mentioned it works by inhibiting your IMP dehydrogenase, which is important for purine nucleotide synthesis. So over here, if you can see on your right side, mycophenolate, it inhibits IMP dehydrogenase, which prevents purine nucleotide synthesis. And this is important for DNA replication. Now, you could say this is semi-selective for lymphocyte, because lymphocytes only have this pathway for synthesis of purines, regular de novo synthesis of purines. If you recall from your first year mole, there are other pathways, such as the salvage pathways, which are found in other cells, not in the lymphocyte cells. So the other cells could utilize this salvage pathway. However, lymphocytes have only this pathway, which is de novo purine synthesis. And if you inhibit de novo purine synthesis, you won't have any purines, essentially no DNA replication. So this is the action of mycophenolate. On your left over here is a repetition of calcineurin inhibitors, cyclosporin and tacrolimus. Essentially, they both act on the same thing, but cyclosporin prevents cyclophilin plus, and tacrolimus prevents FKBP. The end product is inflammatory cytokine genes, which are interleukin-2. Right. Now for adverse effects, really quickly. We already had a question about this to differentiate between both. How to differentiate between cyclosporin and tacrolimus. Cyclosporin, both of them, remember, both of them cause nephrotoxicity and hypertension. If I say neurotoxicity, you need to think more about tacrolimus. If I say the patient has gingival hyperplasia or they start developing hirsutism, this is more for cyclosporin. So again, gingival hyperplasia is kind of very high yield for cyclosporin, but do not forget gingival hyperplasia for cyclosporin, neurotoxicity for tacrolimus. That's it. And yeah, over here, you could see glucocorticoids as well. How does it work? It inhibits NF-kappa B and essentially inhibits formation of other inflammatory cytokines, such as interleukin-2 and the other interleukins in general. Okay. I think this is it for this lecture, and inshallah, nothing gets out of it. Final lecture. A 64-year-old man comes to the office due to urinary frequency, hesitancy, and dribbling. His symptom began insidiously 5 years ago and have progressively worsened. He has to get up 2 or 3 times each night to urinate. Vital signs are normal. Examination shows a smooth, symmetrical, enlarged prostate without nodules or tenderness. There is no suprapubic tenderness. Prostate-specific antigen level is 3.5. Creatinine is 1.2, and urine analysis is normal. The patient is started on a new medication. After 6 months of therapy, his urinary symptoms improve and prostate volume decreased by 20%. Which of the following medications is most likely responsible for the decreased prostate volume in this patient? So again, at the end, you can see a hint for it, which of the following medications is most likely responsible for the decreased prostate volume, so decreased size essentially. And the only drug that can do that are 5-alpha reductase inhibitors. In this situation, it would be finasteride. Okay. All right. A 70-year-old man presents with difficulty initiating urination, weak urinary stream, and nocturia. Digital rectal examination reveals an enlarged, non-tender prostate. He is diagnosed with benign prostatic hyperplasia and is being considered for treatment with an alpha-adrenergic antagonist to relieve his urinary symptoms. His medical history is significant for angina pectoris, for which he takes sublingual nitrates as needed. Which of the following alpha-adrenergic antagonists would be the safest choice for this patient? So something to focus on, his medical history is significant for angina pectoris, and he is taking sublingual nitrates. So this comes to the point of selective versus non-selective alpha-adrenergic antagonists. Phenoxybenzamine and phentolamine should not be given. They do the quite opposite. They are agonists. Doxazosine and terazosin are non-selective. They have systemic effects, and they could worsen your postural or could worsen your hypertension because the patient is already on nitrate. And so the only answer that does make sense is tamsulosin, which is selective for your alpha-1A receptors in your prostatic urethral smooth muscle cells. All right. Now, for explanation for this section, drugs for benign and malignant prostatic lesions. I like to think of it this way, and you have two pathways. You have pathways to relieve your obstruction of your prostatic urethra. You need to dilate it and allow more flow. And then you have pathways that prevent the growth of your prostate and closure or obstruction of your prostatic urethra. To relieve your obstruction, you have your alpha-adrenergic antagonist, and as we mentioned, it works by relaxing your smooth muscle cells in your bladder and the smooth muscle in your prostatic urethra, so it allows more flow. There are two types that we already discussed: the specific and the selective and non-selective. The non-selective, you have doxazosine and terazosin, and they act on alpha-1 blockers all over the body. They have systemic side effects, including mainly, you need to remember, orthostatic hypotension. Then you have alfuzosin, tamsulosin, and silodosin. Those are more selective. They are alpha-1A, and they are found in your prostatic urethra. But their main issue or their main adverse effect is that it affects not only your prostatic urethra, imagine it affects all the receptors in the male reproductive system, including the smooth muscle cells in your vas deferens, which is important for your ejaculation. But if the smooth muscle cells relax over there, the ejaculation will not happen, and those patients would present with ejaculatory problems. They'd have impotence because of lack of contraction of the smooth muscle cells in your vas deferens. But then you have then you have the option of preventing the growth. So if you go back, the main issue with BPH and prostatic cancers and generally everything that causes prostatic enlargement is that you have too much dihydrotestosterone. So if you prevent formation of dihydrotestosterone, you'd have the reduction in size of the prostate gland. And this is the importance of 5-alpha reductase inhibitors. They decrease conversion of peripheral testosterone to dihydrotestosterone. And then you could combine between both of them and have your perfect result. But for 5-alpha reductase inhibitors, you have two main drugs, finasteride and dutasteride. The more potent one would be finasteride. Adverse effects, again, remember, you're preventing testosterone from forming. You have anti-adrenergic activity, androgenic activity. And this is why they present with sexual dysfunction, generally impotence, decreased ejaculation, all of that. And they could also present with gynecomastia. But remember, gynecomastia, because testosterone now is not getting converted to dihydrotestosterone. Testosterone levels would start increasing, and some of it would start converting to estrogen. And this estrogen would eventually lead to gynecomastia. But which of them is for, if we're comparing alpha-adrenergic antagonists and 5-alpha reductase inhibitors, which one is for short-term use? Alpha-adrenergic antagonists. 5-alpha reductase inhibitors, because it acts on your prostate and it reduces its size, it needs a bit of a period to start functioning. طيب. So this is for the main regimen you have. Then you have other miscellaneous drugs such as the prostaglandins, the prostaglandin PDE5 inhibitors. And so you have sildenafil, tadalafil. Those work by how? They increase your levels of cyclic GMP through, it's very similar action to nitric oxide. Increasing cyclic GMP would eventually lead to smooth muscle relaxation. And as we mentioned, very similar to nitric oxide activity. They have a lot of indications. Like we mentioned previously, we already spoke about how it could be used for pulmonary hypertension. Over here, it could also be used for erectile dysfunction because it causes vasodilation and it allows more blood flow. Finally, it could be used for benign prostatic hyperplasia to allow more flow. But specifically, as you can see, tadalafil on. But if we're talking about adverse effects, again, you need to think about anything that causes increased blood flow. So if you have vasodilation, you'd have more blood flow, and this causes what? You'd have more flushing, you'd have more headaches, you'd have more hypotension in case, because you have the vasodilation. All of those are adverse effects that you need to think about when it comes to phosphodiesterase 5 inhibitors. Finally, for contraindications, those drugs are contraindicated to be used with nitrates because it could worsen your hypertension severely, along with alpha blocking agents. So both of them cause vasodilation and they cause hypotension. But I think I mentioned at the beginning prostaglandins. That was a mistake. It's phosphodiesterase 5 inhibitors. My apology. But finally, for prostatic cancers, again, the main issue with prostate cancers is high DHT, and so you need to reduce the levels of testosterone. And so how you could do that is through three main ways: medical castration, where you give the patient gonadotropin-releasing hormone agonists and antagonists, usually at the same time. So normal physiology, you'd have a pulsatile release of GnRH, which causes a release of FSH and LH. The LH would lead to the release of testosterone. Right? So if you continuously give GnRH, you lack this pulsatile pattern, and so you will not be releasing LH and FSH. Right? So you could give them leuprolide, which is a GnRH agonist. The issue with this is if you give for that first period, the GnRH could actually stimulate the receptors and could release LH and FSH. And this causes worsening symptoms for the first a couple of periods, or the first period the drug is being used. And this is something we refer to as the flare phenomenon. This is why you usually couple it with another drug, which is a GnRH antagonist, such as the Garalex, which is again, so you give it during that first period and you have an antagonist, so you prevent the flare phenomenon from actually happening. So those two drugs are given together. Then you have an androgen synthesis inhibitor and androgen receptor antagonist, very similar concept. In androgen synthesis inhibitors, they prevent androgens from being formed. You have the drug abiraterone. And then you have androgen receptor antagonist. You have apalutamide. How I could remember it is Saraha receptor has a P in it, so the drug with a P, apalutamide, is the one that acts on the receptor. Now, one final thing is the side effect. Honestly, I really doubt you'd get asked about. Thus, apalutamide was mentioned. So for the sake of completion, you could remember anemia, aneurysmopenias, and then you'd have two hypers, which are hyperglycemias and hypertriglyceridemia. Hyperglycemia and hypercholesterolemia. Again, very low yield, and inshallah, you'll probably not get asked about. But in case you do, you have that as well. And this would be it for our crash course. Inshallah, you guys found this beneficial. Inshallah, you'll ace your pharmacology questions now. And inshallah, no questions will come out of it. I hope this was a good review. If you have any questions, feel free to text me, email me, and here's the QR code for feedback. Thank you guys so much for attending. I hope you have a blessed weekend and an amazing exam ahead of you. Best of luck. Assalamu alaikum.